about it in 2006, but it took 10 years to convince our neurosurgeons, and Dhananjay Bhatt and Nupur were the real veterans who have now experienced in the surgery in Hirayama disease. So let's go quickly how it evolved. So in 1959, Hirayama described this disease, and we know that it has a single limb involvement. It has got many juvenile anterior horn cell, focal anterior horn cell, or a benign form of motor neuron disease also. But of course, in 1984, Professor Gauri Devi coined the term monomelic because in India, we realized that this Hirayama disease, which is not just restricted to the upper limb, it also affects the lower limbs as well. So we coined the term brachial and crural monomelic amyotrophy. And we know that most cases are from Asia. So originally 38 cases were described by Hirayama, and the first autopsy case was done in the year 2000, and that was accidental death of the patient, and they found that there was an ischemic lesion of the lower cervical cord, and that's what possibly so possibly the researchers thought that this is not a degenerative disease, but possibly an ischemic event. So it was called as a focal ischemic poliomyelopathy. So we published on a large series of monomelic amyotrophy of about 280 cases way back several years ago. So what is the mean age of onset? Many times I get references saying that monomelic motor neuron disease in a 50-year-old man or a 60-year-old man just because a single upper limb is affected. But that's not true. The mean age is around 19 years, and we have rarely seen patients at 14 years and around 25 years of onset. So what classically the weakness and wasting is in the CAT1 distribution in the patients, and generally this evolves over 2 to 5 years. Of course, they say it is self-limiting, but why is it self-limiting? The damage is already done in the patients, and then there's nothing more to lose. So what are the additional features apart from the pure motor syndrome that these patients have? It's a cold paresis. That is, there's worsening of motor symptoms. Is there a timer? I don't see the timer here. And stiffening of the fingers on exposure to cold conditions is very, very characteristic of Hirayama disease. And they can also have other autonomic features like hyperhidrosis, vague sensory phenomena. Recently, we've had patients who reported Lermits phenomena in classical Hirayama disease. So what is the pathophysiology exactly? Now it's almost confirmed that this is a cervical flexion-induced compressive myelopathy, and the cord gets compressed particularly during flexion, leading to arterial or possibly venous congestive myelopathy. And there is an increased kyphotic angle, and there's an unequal distribution, and there's a lack of posterior epidural ligaments, as I would be demonstrating in the radiology soon. So what's most common? The distal weakness, as I said, in C7, C8, T1 distribution. Brachioradialis is spared for whatever reasons. We do know that the neurons supplying the brachioradialis muscle is possibly resistant to ischemic damage. Occasional fasciculations. Mini polymyclonus is very, very prominent. Hyperhidrosis. And as I said, some vague sensory symptoms. Although we thought this is a lower motor neuron syndrome, it's not true. There are several patients with hyperreflexia, and that's what makes us look for a diagnosis of motor neuron disease. I've had patients with classical Hirayama disease, and a diagnosis of MND was made. Rilutar was started, and the patients expressed that they wanted to commit suicide after Googling what MND was. So we really have to be very careful before we make a diagnosis of MND in these young patients. So classically, what do we see? So I don't know if this pointer works on this. So you can see the distal wasting and weakness. You can see that the brachioradialis is very classically spared. It's not just unilateral, it can be bilateral. You can see the lower figures over there where the distal wasting weakness, and you can see very classical. Now if a patient walks into our OPD with the hands like this, we're almost sure that we're dealing with the case of Hirayama disease or monomelic amyotrophy. They can come with the wrist drop. So this is the classical picture. So sometimes you may have difficulty in differentiating from MND. We pointed out that this is something called as the reverse split hand syndrome. Classically in ALS, you have the median nerve distribution muscles getting involved, but in Hirayama, it is the C8T1 or the hypothenar muscles get involved, as I have pointed out over there. Of course, in both, you can have the FDI involved. So we labeled it as a reverse split hand syndrome. So what's the MRI features that we classically see in these patients? You can see there is a loss of the cervical lordosis, and we also, you can, later on I will show you, there is a reverse cervical lordosis instead of the common, normal cervical lordosis. And you can see that there is a, is there a pointer? I have to use this. Okay, you can see the anterior horn cells, this is the gliosis, and this is termed as the owl's eye appearance, or it can also be called as the eye of the snake. You can see there is the anterior horn cells which are gliotic, and you can see the detachment. That's the problem with this. I think once I move that, it's going to be a problem. So you can see that in the axial section, there are two white dots which demonstrate the anterior horn cell gliosis, and that's the snake eye appearance. And what's more, you can see the first picture where you can see the, oh, I think this, you don't have pointer for this, for me to show. So pointer hai, because each time I touch it goes away. So this is the epidural venous plexus, or the engorgement that we see in flexion position. So how do we do the flexion position? Nowadays we put the patient in the prone position in the MRI gantry, ask them to hang the head down at the edge of the gantry and then do, and we get very good flexion studies, because in the supine position patients have difficulty in flexing their neck comfortably. So you can see the snake eye appearance, and you can see the atrophy on one side which is unilateral, you can see, and the normal one. So very classical picture. As I said, you can see the normal cervical lordosis have put up. You can see the cervical spine loss, as well as there is a reverse cervical lordosis. And then of course you can see the epidural venous plexus, and then in contrast, all patients we do a contrast so that we can see the epidural venous plexus which is enhancing. So this is very classical picture of the Hirayama disease. So again another case, as you can see, classically the cervical lordosis is lost and there is a reverse lordosis. So originally it was described that it's a single unilateral limb, but we know now you can have bilateral upper limb Hirayama disease which can be bad. So clinically it's, the age of onset is the same, the MRI findings are identical, but it's no longer unilateral. You can also have many patients, in fact it is asymmetrical and it is bilateral. So you can see here clinically, I already showed you the patients with bilateral involvement. You can have distal wasting weakness, very classical, and the brachioradialis is sped. And the evolution is, as I said, usually over 2 to 5 years. So if you look at the bimelic AMI trophy, also you have the classical MRI features of epidural, venous engorgement and enhancement. So the same findings, so identical findings, whether it is single limb, whether it is both the upper limbs, whether it is distal or whether it is proximal. So what's more interesting, we saw that it's not just the distal muscles which are getting involved in Hirayama disease, but also the proximal muscles, and of course we've got all of these published. Again, as I said, the mean age of onset seems to be the same, the evolution remains the same, and we have to identify particularly not the classical ones of Hirayama disease, but also the proximal forms of Hirayama disease, where they can have unilateral shoulder girdle wasting, bilateral shoulder girdle wasting, they can have proximal distal forms. And of course, taking up these patients for early surgery will benefit a lot, and we could arrest the progression of the disease. So you see, anybody would just make a diagnosis of FSHD or a muscle disease, you can see the scapular winging, bilateral progressive shoulder girdle weakness, and the distal muscles are normal in this patient. So this was a 26-year-old man, as you can see, I put up the details, and another patient of 28 years who had progressive proximal muscle weakness. What gave us a clue was that the patients had some BRIS reflexes, and this gave us a clue that possibly, and nowadays whenever we have such cases, we just do a flexion MRI, and lo and behold, many of them have Hirayama disease. And again, as I said, even if it's the proximal form, the MRI features are identical, but the dural detachment appears to be a little more higher. It's possibly at C2 or even at C3 level. So you need to get this patient. So this is the proximo-distal form. You can have the proximo-distal. All of these patients had diagnosis of SMA, had diagnosis of young juvenile ALS, juvenile MND. But of course, over the years, we have also learned once the MRI was available. So you can see the proximal and distal wasting. And even here, you can see that even with the severe proximo-distal wasting, the brachioradialis is pretty sped. And of course, again, as I said, the MRI remains identical in all of these patients. So this is a very latest case. My resident came and told me, I think it is FSHD, but when I checked the patient had BRIS reflexes, I said, why not do a MRI, and then you can see the classical features, and we have already operated on this patient. So you can arrest the progression at least, but of course I will show you in the surgical outcome. So Hirayama disease is just not sporadic, it can be also familial. We've seen more than 5 families till date. And you see these two brothers, one is 59 years old and the other one is 45 years old, and both of them the brother has a single limb, whereas the younger brother has bilateral involvement. Of course, they came very late into the illness to us because they are referred as Hirayama disease and whether surgery can be done. So this is a proband who was young and 27 years with classical Hirayama disease, and then this is his father who also had bilateral distal wasting weakness, and you can see the MRI showing the classical features. As they get older, because the neck cannot be flexed much, this epidural enhancement may not be as prominent as what we see in the younger patients. So this is another two brothers who had classical Hirayama disease. So we know that long back wasted leg syndrome was described. Now what we have found in the MRI is that the detachment is not just restricted to the cervical region, but it extends quite a lot even to the thoracic region. Of course, lumbar region we have not been able to do much flexion. So you can see when this patient had come with, our patient came with left upper limb and mild left lower limb involvement, and so when we did the MRI, you can see the extensive dural detachment. The dural detachment not just restricted to the cervical region, but the thoracic region also there is a dural detachment. So likely that these patients with Hirayama disease have a dural detachment in the entire spinal cord, and what we can see is only cervical. Now that when we do the prone position and even the thoracic spine slightly bends, we are able to get, and most of our patients have the detachment extending to the thoracic region as well. So you can see this, it is so far, it just extends up to the thoracic, lower thoracic, and this is the snake eye appearance which the patient has. So let me just conclude with this clinical feature. So it affects the young males. We don't know why, but we have about 3 or 4 women on whom we have operated also. So mean age of onset is around late adolescence, predominant motor symptom, recognizable autonomic symptoms, causes moderate to severe irreversible disability. Familial forms are well described, and now we are quite convinced it's a cervical compressive myelopathy with ischemic or venous congestive myelopathy. Of course, each time I give a talk, many more patients are getting referred to NIMHANS because neurologists are quite scared to give to their local neurosurgeons because they're not experienced and they're worried that these young patients, because I'll show you one of the cases later on, how the surgery itself caused severe damage to the patient. So I'm just going to show that we also reported on extended form. So Hirayama disease can affect the lower limbs also because it is a compressive myelopathy. So you can see these are 2-3 examples over here where patients had spastic paraplegia as well after a stationary period of upper limb Hirayama disease and went on to have classical features, and we have operated on these patients, and the first patient had bladder involvement which improved very well, and the second patient also was quite stiff, spastic gait improved a lot, and he came to us actually when he was quite old at the age of 45 years. And you can see the cord is literally pinched over there. Such severe compression, and you can see the very extensive venous engorgement in this patients who had lower limb involvement also. So let's move on quickly to the surgical intervention. We know that there are several reports in the past, and the current study we have now operated almost 212 as of yesterday, which Dr. Nupur gave me the data, is around 212 cases we have operated in the last 7 years. But what we analyzed was around 136, and you see that the improvement in the neurological symptoms was in almost 84% of the patients. So anterior, and there are several reports in the past. You can see 48 cases, and of course, in 2014, way back 10 years ago, they have shown multi-level anterior cervical decompression with fixation, giving rise to 100% improvement in the neurological symptoms. And of course, we were also quite surprised. So this surgical outcome paper we've submitted and it's under review. And as you see, we have about 212 cases operated in the last 7 years, and single level is what we follow now, and it's 198 cases on single level. Initially, we started with the posterior approach. Of course, it's very morbid, severe neck pain, restricted movement. Patients were unhappy. Our surgeons were also unhappy. Then we went into anterior. We did about 2 levels. Then Dr. Dhananjay and Nupur said that 1 level is also as good. And now even internationally, most of the Eastern countries, they do single level. So we really did a lot of assessment, Fugel-Mayer, Jepson-Taylor, and Handel dynamometry to quantify that the patients are indeed improving, and then we found. So how do we select the cases? So we always select cases who are in the progressive phase of the disease, not when it is already attained stationary or in the burnt out phase of the illness, because many come, as I said, the 45-year-old man came, but he had a late progression, so we still took. So progressive worsening of functional disability, a second phase of progression, a single limb is involved, it is stable, then another limb gets involved, then we of course take them for surgery. And MRI of course should show uniformly the epidural enhancement on flexion with contrast has to be done in them. So initially, as I said, posterior level was done with iliac bone graft, and but now currently for last almost 6 years we just follow the single level anterior discectomy at the C5 C6 level commonly, and the artificial bone graft is being put instead of the iliac bone graft. So I'll just show you some examples, and this is an 18-year-old boy who came with classical Hirayama disease. You can see the MRI. This is with the non-contrast and this is with contrast, and Dr. Nupur does this flexion extension of the neck to look at, he calls it the bending angle. So you can see normally it's around 69 degrees in 2-3 cases, and that's the mean. And whereas in Hirayama disease is found it's almost 91 degrees. So this much of increased neck flexion happens in this patient. We do not know whether they have lax ligaments. Usually Dr. Khadilkar has reported that they have long necks. And usually you see these patients are quite lean, tall, and they have long necks. And this is the postoperative X-ray which shows a nice fixation, and also you can see the artificial bone graft which is nicely taken up in the cervical spine. And the cervical lordosis is returning almost to normal. You can also see the pre-op 6 months later. We had the, this is the pre-op scan, and this is the post-op scan, which shows a much reduction in the epidural enhancement and in the space. Again, at the end of 24 months, we did some post-op MRIs, and this is a surgical scar which is taken up very well. So he has been doing surgery at C5, C6 level, decompressive surgery and with fixation. So we did objective assessment, we did the Jepson-Taylor, and it showed very good improvement at follow-up. We did serially 3 months, 6 months and 12 months, and we found that the improvement was very good and patients were very, very happy. Handheld dynamometry also showed, you can see that almost 80% of the patients reported good improvement. And you can see one of these patients who pre-op, and many of them are young, they're software engineers, they're unable to use their keyboard, they're unable to use their laptops, and that's so disgusting to them. But after the surgery, you can see the pre-op, so much of weakness is there in the small muscles and the long. And this is 3 months post-op, very good improvement, and also even the small muscles, the opponents has improved very well. Another patient also who had severe weakness, of course I have videos, I don't have time to show this video, so I just put up the pictures, and this patient also had very good improvement. So we had a long-term follow-up. Of course, we did not talk about Hirayama disease and surgical outcome very soon. We waited for at least more than 5 years to have follow-up on our patients, and almost after 72 months we are really now sure, and we submitted the paper for publication because we wanted to be sure that this surgery indeed helps these patients, and we didn't want to be very quick in our decision making because it matters a lot taking young patients for surgery. So you see that at follow-up at around, the latest we did in 2022, immediately the surgeons were so surprised that the very next day the patient reports that the mini polymyclone has disappeared, the cold paris has disappeared, they're able to use their fingers. So it's a dynamic compression over there. So there's a dynamic ischemia which possibly took reduced immediately after the surgical decompression. So what are we doing? We're fixing up the cervical spine, reducing the forward flexion in these patients. Very few people, like 2.8%, said that the muscle power worsened. We are not sure why. So stability and improvement, as you can see, at 3 months, 6 months and 1 year, 94%, 96% and 84%, they reported excellent good outcomes. And as per Odom scale, we did Odom scale because we do it for cervical spondylotic myelopathy. And you can see here, we were very, very happy to note that these patients had improved so well. So excellent outcome in almost 64% of the patients with what significant motor deficits that they had. Satisfactory in 30 and reported mild worsening, that's about 4 patients. Whether they were still progressing in the disease, we do not know. And again, you see the latest, that is almost after 50 months, you have excellent outcome in 55% of the patient. So this was well during COVID time, we had sent in questionnaires. So we created a validated HD outcome questionnaire, and you can see the excellent outcome was there in almost many of the patients. You can see as far as 44% of the patients. So this was at the end of 5 years of illness. So only 4 patients said that they experienced a mild worsening. So everything is not rosy about surgery in Hirayama disease. Selection of the case is very important, and surgeons have to also, Dr. Nupur doesn't take the patient. He gives them time, he gives them 6 months or 1 year or sometimes 3 months. We give them a hard cervical collar to stabilize, give some yoga for the neck. Of course, Nimans has an integrative yoga center, so we try to make use of that facility over there. So this boy was a 17-year-old boy who came almost literally shattered and this thing. So he was operated in an outside hospital very enthusiastically by the neurosurgeons in March 2017. He had a left upper limb weakness wasting. He refused to allow me to take his pictures. And then you can see they did a multiple level posterior decompressive surgery, and no fixation was not done. Only laminectomy was done at 4 levels, and the patient was left like that. And when we saw him after 6 months, he had profound kyphosis. You can see he had profound kyphosis, and he developed severe pain in the neck. And what was worse, he developed wasting and weakness of the opposite limb because of the compression that was caused because of the kyphosis and because of the surgery. So many times we want to even sort of give advice to the neurologists to be cautious when you're referring your cases to the neurosurgeons. I mean, let experienced I know that every day they're doing for spondylotic myelopathy, but so many of them are not done for Hirayama disease. So we should not cause more damage than what's already occurred. So case selection is very, very important. We do pre-surgical counseling, post-surgical assessments, okay? So what's the post-operative complications that you can get? So local pain for a few weeks, restricted neck movements, which improves. They can have transient weakness, maybe because of post-operative edema. 2 cases, incidentally, the 17-year-old boy, we did an anterior decompression, did a fixation, and his disease was stabilized. I forgot to tell that. Okay, and 2 cases reported mild post-operative worsening. 1 case with posterior approach had higher level subluxation. So this is what the surgeons are worried. If you fix up C5, C6, whether there will be a subluxation and degenerative changes at the, but we are doing serial MRIs for these patients to see, but thankfully none of these patients have had at the end of 5 to 7 years post-operative. So these are the complications that our surgeons envisage, that may be early onset spondylosis, enhanced degeneration at the adjacent level. So decision should be taken to carefully before you take up the patients for surgery. Anterior approach, single level, is more than enough for these patients with Hirayama disease, and give them enough counseling because they're quite worried, young men who come to us with this disease. And at least we can arrest the progression, if not improvements. I usually tell them our purpose is to try and arrest the progression, and not that you're going to have improvement, but they're so happy. So they know that their expectations are not so much, but when they improve, I mean 80%, 90% improvement in the motor disability is really wonderful for the patient. So let's summarize. So once again, it affects young males. We should know that the mean age is around 90 to 20 years, and not make diagnosis as monomelic MND when they're in 50s and 60s. And we know that familial forms do occur for whatever reasons. Many HLA studies have been done. We did whole genome sequencing in about 10 patients. We did not find anything. So whole genome scanning was done. So we really do not know what's the genetic basis on these familial forms of Hirayama disease. And so we are sort of convinced now that this is a cervical compressive myelopathy and giving rise to ischemic but venous congestive myelopathy. So we thought that we should coin it as cervical flexion-induced myelopathy, and of course Hirayama described it, and we should give all honors to him, and we should identify these very early and offer surgical intervention, because sometimes in very few months they can progress, and then the disability is permanent because there's so much of anterior horn cell damage. So with that, let me end, and thanks Dr. Dikshit and Professor Sanjay for inviting me. The beautiful place of Raipur. I was very much impressed with the greenery around here. As I came from the airport, so much of greenery, so many saplings, and that's my another interest is at Nimhans. Wherever I find mud, I will put a plant or a tree over there, and I think Dikshit should come. Thank you for inviting me to this beautiful city, and I could share my experience and our experience, not mine, our experience on this fantastic disease. It's very common, no? It's very common. we are doing, every month we are doing 3 to 4 surgeries. So it's become very common, and now that we keep talking about this, more of the neurologists are referring the cases to NIMHANS because the expertise is there currently. Thank you once again.
Thank you, ma'am. One question.
Yeah.
We used to study that the young males playing sports, heavy physical sports or contact sports, are usually in risk of getting hirayamas. Is it still, does that still hold true?
See, those were identified risk factors in the past. Even Madam Gauri Devi has submitted one on risk factors like drawing water from a well or heavy physical. See, that's a risk factor for MND that's been shown, like veterans or the soldiers in the US have been propensity for anterior horn cell damage, and that could trigger motor neuron disease, and that's well established sort of as a risk factor for MND. But possibly they are flexing their neck a lot. So maybe they have an inherent tendency to develop Hirayama disease, and these are just trigger factors. I think we should think like that, because all of them have long necks, and you saw the flexion extension 91 degrees, and that's pretty common in most of the patients. So Dr. Nupur is very particular. He does all of these pre-surgical exercises. He should be convinced that this patient will improve with surgery, which every surgeon wants them to improve. So when he's convinced, they take. But now it's, Dr. Alok was also there. Now Dr. Alok has taken up much more cases doing. So we've sort of established, and as I said, our neurosurgeon started the Hirayama clinic now. So they have patients, and now the surgeons see the Hirayama patients, and then they refer to us for clinical evaluation. So that's a tragedy now. But well, I'm sure all over the country, neurologists are first going to see them because it's wasting weakness and without any surgical symptoms. So it should be identified, and then now. I think surgeons should really take it up.
Why most of the cases of Hirayama, their onset is in full season? And what is the role of cervical collar in such situation?
See, okay, thank you. Yeah. See, autonomic fibers, we also saw, I have just shown, we showed that the sympathetic skin response is abnormal in these patients. So because it's a compressive myelopathy, possibly the sympathetic system is also getting involved because ischemia of the sympathetic, yes, more. But when we saw cases with cold paresis, we had a patient from Assam who had cold paresis for 10 years and then developed Hirayama disease. So we have published that paper. Actually, it's a mother and son who came from Assam. So mother had only cold paresis for more than 10 years. Then she developed. So many patients like paramyotonia congenita. Our Bangalore patient has gone to Assam, then developed paramyotonia congenita and came, because you need that sort of a cold environment to develop these things. And it's pretty common. It's very disturbing to patients. They put their hand in warm water, then they have to rub their hand, and then they just put it into their pocket to warm them up in these cold places with Hirayama disease, and then sort of they get improvement with that. And of course, as you said, your second question, collar, see, even surgery, what are we doing? We're going to fix up these vertebral bodies so that the flexion is reduced. So it is a flexion-induced ischemia of the spinal cord. So ideally, you're just going to do that. But you know, Chinese, they are doing duroplasty, they are doing laminectomy with duroplasty. They have done biopsy of the epidural venous plexus also and found just venous engorgement. Of course, I didn't have time to tell all of these things. But we're just trying to reduce the forward flexion of the cervical spine. And then we have post-op scans where the canal is already widened. So we're just doing that MRI analysis now, pre-op and post-operative. Possibly once that's done, we will have some robust data on the changes following fixation. Of course, it's a nice disease to talk about lots. Yes, sir.
Nali, could you comment on getting a prone MRI done in this group of a patient? Is it essential? Because most of the radiologists, they are not comfortable, they are not doing this protocol.
So we were doing supine only. We were keeping a sandbag or a wooden wedge-shaped thing for them to do flexion. But you know, sometimes for 20 minutes, 25 minutes, these patients, because Dr. Nupur wants axial T2 also in contrast. So that was additional time. And once in a while, patients did come from outside with MRI, which showed this thoracic epidural venous plexus also, so much detached. So actually, Professor Rose Dawn from NIMHANS, I'm sure many of you all would know, she tried this, why not do prone position? So we are doing that prone position, and in 15 minutes is done, and you can see that very extensive dural detachment. But of course, our radiographers are not happy, because the moment they put them in prone position, the right-left thing changes in the MRI. So everything they have to change the entire protocol over there because the right becomes left and left becomes right, which they are unhappy to do. But sometimes they do try flexion in the supine posture only classically as we have been doing. But if the epidural is not very clear and surgeons don't take up the cases, if the they measure the maximum epidural detachment. And at that level, he will do the surgery. So if it is a C5, C6 or C6, C7, so this maximum epidural detach. Of course, I had Dr. Nupur's video recorded talk, y'all can take it, and he's spoken very well, like in the last meeting for about 20 minutes on the surgical approach in Hirayama disease. So that was really, I thought if I had time, I would actually play that, but I can give it to y'all, y'all can listen to that. Yes, Dr.
Ma'am, thanks for the excellent presentation and excellent work. Congratulations for that. I have one question. You said that it should be labeled as cervical flexion triggered myelopathy, but in most of the patients we do not find the history of excessive flexion in these patients. I mean, they are not engaged in any job where they are exposed to such kind of flexion. So do you think really it is responsible, or there could be some other mechanism responsible for this myelopathy? Because there is no history of excessive flexion. They are normal human beings like us. I mean, they are not engaged in such activities. Despite that, they develop this.
You're right. So that's where they may be having some inherent abnormalities of the ligaments, whether they are very lax, because the dura is completely detached, which are usually fixed by the ligaments. But we also had quite a few patients, because most of these are young students who come to us. And one boy had a very peculiar thing. He's lying on his bed, he puts his book on the floor and bends his neck and he keeps reading. But these are, of course, anecdotal cases, you know. But see, all of us, when we are studying, we have our neck so much bent. When we're reading, when we're writing, even when we are on the computer or a laptop, our neck is flexed for hours and hours. We don't realize that. But these patients possibly have a predisposing abnormality over there. See, they have done dural biopsies and saw that maybe the elastic fibers are abnormal. But we don't touch the dura here at all. So our surgeons refused to give me, when I asked them for dural biopsy, they said we will not give you biopsy because they don't touch the dura, because they don't want to enter into the CSF space at all at any cost. It's everything to do with the bone and the disc. They do a discectomy and fix up the bone and leave it at it. But I think because when you see familial forms and all, there must be something which is going on. Familial, maybe abnormal collagen tissue, abnormal elastic tissue there in the dura and the ligaments, which are very lax. And that's why you can see, and we think that the detachment is in the entire spine. That's why that wasted leg syndrome also again gets diagnosis of MND most of the time. But we tried, in fact, lumbar also, trying to put the legs down. We put a big, like a sofa, made the patient lie down prone to look for lumbar thing, but we were not successful. We did all of those experiments and we did not do. And we did axial at lumbar level to look for the dural detachment. It wasn't so easy for us to. And the crural monomelic hematrophy or the lower limb is so very rare. We hardly have about 10-12 patients, whereas this we have in hundreds now. Okay.
Thank you, ma'am, for a wonderful presentation and enlightening us. One brief question. For those who are not ready for surgery, even after counseling and other things, any tips what to suggest to them?
Yeah, see, what I do is, of course, a hard cervical collar they can use, and sometimes for 2 to 3 years. So that time, many times they'll come back and say, no, we'll undergo surgery because it's so uncomfortable. And if a patient is from Andhra Pradesh or Chennai in that hot weather, nobody wants to wear a cervical collar. But we give them the choice, and many of them do stabilize because that was the original form of treatment for this patient. But they have to wait for work. And sometimes it's also mentioned in literature that they can wear the collar during, I give a hard cervical collar during the day and give a soft cervical collar in the night. Because at night only your neck may be in various different positions which can cause ischemia and sort of compression. So you give a soft cervical collar, and some of them said yes, they're quite comfortable, they're quite, and so this thing, and of course Nupur likes yoga a lot. He gives them some neck muscle strengthening exercises so that the paraspinal muscles become strong, so the flexion might reduce. But we have not done any systematic work on that. And of course physiotherapy and other things which are graded physiotherapy.
Thank you very much. Thank you very much for it.
Thank you. Thanks.
Like to call.
We would like to call Dr. M.S. Jory for the next presentation on the topic of NMO spectrum disorder update.
One announcement from the organizing body that please vacate your rooms during the lunch hour. Thank you.
Thanks to the organizing committee for giving me this chance to bring out certain points regarding NMSO, NMOSD. Well, earlier it was described as Davis disease, supposed to be monomelic, but we knew that it can recur, and then for many years it was considered to be some form of multiple sclerosis only. However, it was as late as early 2004 or something that Lennon described this as found actually the antibodies against the aquaporin 4, and therefore it came to our knowledge that this is a kind of immune-based astrocytopathy. So mean age is around 40 years, and male to female ratio here, female to male ratio is 9:1. Prevalence is less common. You can see it is 0.5 to 4 per lakh of population, and recurrent attacks, more than 90% face this recurrent attacks, and which leads to cumulative disability. So pathologic reasons are heterogeneous and different. Multiple sclerosis. Actually, we have to distinguish it from multiple sclerosis because same treatment as multiple sclerosis, actually it can give rise to worsening of this condition. So that distinction is very important, and pathophysiologically it is very distinct from multiple sclerosis. So the antibodies are there, but they may be there in the intervening period also. So that may not be the whole story. Disease expression actually requires something else also, like say local breakdown of the blood-brain barrier. So seropositivity can be detected long before the onset of clinical disease. So local inflammation, breakdown of BBB, oxidative stress, and immune tolerance breakdown may be the factors which lead to onset of the symptoms in a particular patient. So these are the pathophysiological mechanisms. So many things are involved: eosinophils, macrophages, immune-based T cell damage is there. So if we know about these things, then that has led to, once we knew about these things, this has led to newer forms of treatment which can be offered to these patients. Pathologically, it involves more of gray matter, as you can see. So it is ever evolving, the understanding. 90% have 1.3 relapses on an average in a year. 50% present with transverse myelitis, 35% with optic neuritis, and 10% present with both. So overall, more than 85% patients will have these two features or one of these two features. So other features that may be included are area post-tremor syndrome, brainstem syndrome, diencephalic syndrome, cerebral syndromes. Earlier it was thought that probably cerebral involvement would rule out NMO, and that is not so. Then neuropsychiatric presentations, uveitis, myeloradicopathy, and acute myopathy with rise in CPK. So when we are trying to diagnose, the latest criteria, as is shown here, reported in 2015 by the International Panel for Diagnosis. If we know the status, positive status of aquaporin 4, then you need only to have one of these core clinical features, which are listed here: optic neuritis, acute myelitis, so on and so forth. And secondly, thirdly, exclusion of alternative diagnosis. So you have to rule out. So basically it is a disease of exclusion, that you rule out other diseases. However, if the status is not known, or if the aquaporin 4 status is negative, then you need to have at least two core clinical features which occur as a result of one or more clinical attacks and meeting all of the following criteria. At least one core clinical feature must be optic neuritis or acute myelitis with LETM, long extending, or area post-tremor syndrome, one of these. And dissemination in space, two or more different core clinical characteristics. Fulfillment of additional MRI criteria, as we will show in the next few slides, and negative test, of course, and exclusion of alternative diagnosis is common to all. So additional MRI criteria would be like this: in acute optic neuritis, T2 hyperintense lesions, I mean more of the optic nerve, say more than half the length of the optic nerve, or involvement of the optic chiasm, that should be demonstrated. For acute transverse myelitis, 3 contiguous segments or more of focal spinal atrophy with past history of NMO, or active lesions in 3 contiguous. However, it is not a must, but it helps in the diagnosis. And area post-tremor syndrome requires dorsal medullary lesions. For spinal, these LETM lesions, increased signal intensity, central cord predominance that we have already seen in the pathological characteristics. Rostral extension of the lesion can occur into the brain stem. Well, these are the few examples you can see that very long segments are shown here to be involved. And in the third panel, you can see that it is extending to the brain stem area also. And in the last one, you can see in the lower down area, there is marked spinal cord atrophy. So if there is past history suggestive of NMO and you find this, so that is compatible with a past event of NMO. So the fourth, last panel shows the atrophy. For optic nerve, unilateral or bilateral, increased length extending more than half the distance, or optic chiasm involvement. You can see that in the first panel, almost whole of the length of the optic nerve is involved, more than 2/3. And in the third panel, you can see that optic chiasm is getting involved. So these are the additional criteria if your aquaporin 4 body is negative, the test is negative. Well, antibody status, the serum testing is always better, and cell-based assays are required for a definitive diagnosis. Other assays are not so sensitive. Because you are basing your diagnosis in that, you need a very good report for that. So cell-based assay should be asked for. Red flags for misdiagnosis would be that acute onset, which may suggest some vascular event, or a chronic progressive course, which is a very, very rare thing in NMO, more than 4 weeks. Active coexisting disorders that could mimic clinical presentation, maybe they have been listed here. Several lesions showing gadolinium enhancement for more than 3 months, and presence of CSF oligoclonal bands, which are found in certain percentage of NMO patients in the active phase, but otherwise they are rare and they are pointing more towards the diagnosis of multiple sclerosis. So relapses, they can be likened to a kind of neuroimmunological stroke with poor prognosis for recovery. With each one you can get added up. The data shown here is that they may be legally blind, and 41% become legally blind ultimately, and 22% require walker within 5 years of disease onset. So lot of morbidity is associated with these recurrences. So that is the reason that we should try to prevent these recurrences. Predicting relapses is not very good, but however, female sex, younger age, racial differences, they do exist. Disease duration, if it is less, then more relapses may be expected. Within a year, as I said, that 1.3 relapses may be expected. Presence of contrast enhancement of MRI lesions in acute phase carries a higher risk of relapse. Medullary lesions, focal cord atrophy, cord lesion length may have poorer prognosis, as already atrophy has set in. So this is a very high specificity antibody, aquaporin 4, and varying sensitivity with cell-based assays. With other ELISA methods and others, it is not so sensitive. Let us come to the next slide. So seropositive versus seronegative, more likely to be have in seropositive cases. They are women, as I said, the ratio is somewhere 9:1. Systemic autoimmune diseases like say SLE, Sjogren's syndrome, etc. may be associated in these seropositive cases. It may be unilateral optic neuritis or optic neuritis with myelitis, and relapses. These are the features expected to be there in seropositive ones. Anti-MOG antibodies, sometimes when the seropositivity is not there, say aquaporin 4 is negative, often they may be positive for MOG. And this is the group where the diagnosis is more difficult, not settled, that are they really NMO or they are MOG associated, because a lot of overlap is there in this particular group. So you have to apply the diagnostic criteria more stringently in these groups where it is negative, and you may find some other diseases. However, if it is negative and MOG is positive, then you can expect a more benign course. These are the distinctions. Other laboratory tests that can be done are like these. CSF analysis, moderate pleocytosis, say 50 to 200. It is more prominent than in multiple sclerosis, where usually we expect less than 50 cells. However, if the count is say more than 200, probably we are dealing with an infectious kind of myelitis. So count is somewhere this, it is raised, but not, somewhere in this spectrum. So cell count may be normal in 40% of the patients. And if they are raised, they will be probably less than 200. Oligoclonal bands positive in approximately 30% of cases only during relapses. In the remissions, it may disappear also. So IL-6 and soluble IL-6 receptors, they are higher in the CSF of NMO patients than of MS patients. So MRI of the brain, there are so many lesions. As I said earlier, it was thought that NMO involves causes only myelitis and optic neuritis, but brain lesions are also there, and many brain lesions are compatible with the diagnosis of NMO. So lesions involving dorsal medulla, giving rise to area postrema syndrome of say persistent unexplained nausea, vomiting, giddiness. Periependymal surfaces of fourth ventricle may be seen. Similarly, aqueduct or third ventricular periependymal surfaces are involved, so also lateral ventricles. But in brain lesions, you can also see some diencephalic or certain other brain lesions as well, but they will be distinct from MS lesions, where you see paraventricular finger-like T2 hyperintensities. So some examples are shown here. So in the top panel, you can see the medullary lesion, and thereafter you can see the periaqueductal nature of these lesions. Here it is a kind of thalamic involvement which is occurring, say diencephalic involvement, these two panels, and brain involvement can be there in such forms. Now you can appreciate that either it is a periependymal or some other lesions, kind of lesions are there, but they are certainly unlike MS lesions, where you see ovoid bilateral periventricular T2 hyperintensities. So that way these lesions can be compatible with the diagnosis, and most often they would not give rise to certain symptoms, but diencephalic syndrome is known. Sometimes encephalopathy, even loss of consciousness is also known in NMO cases because of these lesions which are present. So treatment, currently high dose methylprednisolone is considered as the first line therapy in acute episodes, followed by oral ones. 2/3 of the patients may show good response if administered within 14 days of symptom onset. Earlier the better in acute settings. Plasma exchange, if the patient is not responding to this, then you may go for plasma exchange. However, it is unclear if IVIG has any therapeutic efficacy in MNO-SD. It has not been shown properly that it does work. Does it work? In failed circumstances of plasma exchange and IV steroids, some people have used IV cyclophosphamide. We all know that it is an anti-cancer drug and can lead to certain side effects. Now, long-term immunosuppression therapy would be targeting the prevention of relapses of NMO. So that is important. Aim is to hasten recovery from acute episode, which is sometimes possible even with them. and prevent relapses. That is the main purpose, and thus minimize the risk of disability. So a variety of off-label immunosuppressants have been used, including azathioprine, prednisone, mycophenolate, and rituximab. Their use has been based on observational clinical studies. The real RCTs are not there to support their uses. Immunosuppression reduces relapse compared to no immunosuppressive therapy. So if you don't have anything else, you can use at least azathioprine and steroids. Many disease-modifying drugs used in MS patients, especially say natalizumab, it may actually worsen. Interferon doesn't help. So in the course of the NMOSD patients. So among the off-label drugs used, rituximab has shown most efficacy. Meta-analysis showed annual relapse rate diminished by a factor of 0.79 and EDSS score by a mean of 0.64. Induction therapy uses either a fixed dose, you know all, that two kind of doses are used with the rituximab. Newer studies have identified several key immunological targets like complement system, IL-6 receptors, and B cells. And based on that, some newer molecules have come. Now, 4 recent randomized placebo-controlled studies have shown the efficacy of eculizumab, satralizumab, and imabiblisumab. Now, eculizumab is a C5 inhibitor and a complement 5 inhibitor. In a phase 3 international study, PREVENT study, only 3% in eculizumab arm, eculizumab plus background immunotherapy had relapse compared to 48% in the placebo plus background immunotherapy at the end of 96 weeks of observation, follow-up. So it has a relatively rapid onset of action and may be useful in acute stage as well, although studies are not there. Perhaps, I mean, it's so strong, perhaps even background immunotherapy is not required, but more studies would be required before one can pass the sentence on that. It has to be given as IV infusion twice a month, and cost is, it needs consideration for this kind of treatment. Now, satralizumab is a monoclonal antibody blocking IL-6 receptors. Sakura Star, Sakura Sky are 2 international phase 3 trials. In the trials, good responses were seen. I mean, relapse rates were significantly reduced. Now, Sakura Moon study is not yet published, but it is a follow-up of these 2 studies of these patients with a mean follow-up of almost 4.6 years. Some are having a follow-up of almost 6 to 7 years. It has a slow onset of action, but the advantage is that it can be given subcutaneously and doesn't require hospitalization, and much monitoring is also not required. So ultimately, from patient's point of view, it can be self-administered also with no need for hospitalization. Now, in abilizumab, it has a monoclonal antibody against CD19 antigen of B lymphocytes and thus depletes B cells like rituximab, which acts mostly on T cells. This also removes B cell precursors from the circulation, so it has therefore better action. The phase 3 trial was an momentum study. These are the results. It significantly reduced the relapse risk. It eliminates plasmablast and B cells also, thus reduces immunosurveillance of the body. Thus risk of certain cancers and PML is increased, and 6% suffer from hypogammaglobulinemia because of the involvement of B cells. So schedule parallels rituximab, the kind of drugs you give, the doses, etc. So established and emerging biomarkers, serum aquaporin 4 is a well-established biomarker. Absence of oligoclonal band if it is found. Optical coherence tomography is often done in these patients, but that actually may just show the damage which has already been suffered by the optic nerve. May not be of much help in differential diagnosis, may be helpful in follow-up studies. So MRI, that importance we have already seen. These are the kind of differences which are there. So this actually is important because you have to distinguish it from the multiple sclerosis. Thank you.
Excellent. question, sir.
Dr. Nalini evoked one long memory. In 84, I was with Dr. Gauri Devi. At that time, she was coining this term, monomelic. There was some report by Dr. Chopra from Chandigarh. So she said it is not proper to call it this wasted leg syndrome or wasted hand syndrome. It is better to call monomelic. And as residents, we used to, Jai Ho, yes madam, this is the thing, you should call it. That's the thing. Okay, thank you.
Thank you, sir. Excellent presentation, sir. Any questions? Thank you, sir, for your excellent presentation. Next.
Now I will request the chairperson to give away the memento to Dr. Monica ma'am, Dr. Nalini ma'am, Dr. MS Jori sir. Dr. Monica ma'am.
Thank you, sir. Nice meeting you.
Now I will request the speaker to felicitate the chairperson. Dr. Umesh, sir, please give away the memento to Rashmi ma'am.
So plan is to have a quick lunch and we'll gather again at 2:15 for post-lunch session, and that's only going to last for 45 minutes or 50 minutes only post-lunch session. I request all the delegates who are having a room here to vacate the room and keep the luggage at the reception.